Jason, welcome to the Health of Business podcast. I am so excited to chat with you for many reasons. I feel like right now you're kind of a rock star in the physio community, coming off like diagnostic imaging push, a great talk at the PABC forum, which was fantastic. So I really appreciate your time today to chat a bit more about diagnostic imaging in BC physiotherapy. Welcome.
Thank you. Yeah, thanks for having me. And before we get started, thank you. I want to just give you a congrats for your board appointment to PABC.
Uh, Thank you. I'm really excited. I can tell it's going to be a steep learning curve, but I'm really excited to be a part of it and to have it more formal. I've been involved in lots of these task force, like we were kind of just chatting, but it feels really great to represent the Okanagan as well. I never thought I'd even live in the interior, and here we are representing it. So it feels really, really great. So, um, I would love just a bit of background and learn a little bit about kind of your history in physio and how you got involved with PABC. What is your background and your involvement and your role at PABC?
Yeah, so before I was a physio, I was actually a PE math and science teacher. I was always
Amazing.
interested in physio, medicine, PE, science. So I did that for a few years. Then I went into physio school, did a couple of years in private practice. And then as a teacher, I've always loved working with kids. So I did about 9 years at the Queen Alexandra Center for Children's Health as a school-based physiotherapist. And then I moved up to the Comox Valley where I work in private practice part-time, pediatrics, vestibular, are my two specialties. And then I was fortunate enough about 4 years ago to get the physical therapy knowledge broker job with Allison Hoons.
Mm-hmm.
And then that kind of then bridged over currently in my current role as the Director of Advocacy and Research with PABC. I kind of now I can say that at full-fledged I'm a physio geek. So in my role of advocacy and research, I don't have to be shy about that. So how I started doing some of these position statements is some people don't know this, but there was actually a petition to stop BC physios from doing dry needling, and so I was asked to do a scoping review on it and give that information to the college to see if there was any risk. And long story short, there's about 100 references to say that when physios do dry needling, it is safe. But apparently I did a good job. So then after that, that's when Andrea started tasking me with these other position statements. And so then the in-between one before the diagnostic imaging one is with my pediatric background. We also did a child youth with supports needs engagement report as well, where essentially I look at all the research is, do a lot of consultation and collaboration, come up with these position statements with the help of usually 20 plus physios that are on task force and then the help of the board editing them. So long story short, that's kind of how I got into this work.
Amazing. Well, you're clearly doing a great job because we've made some leaps and bounds over the last couple of years and seen some really, really awesome stuff. So congrats on the new role and title. That's like awesome and so exciting. And thank you for all the work that you've been doing. I think, it's so exciting to see just the progress and the changes that have happened even in my 12 years of being a physio. Like the research has really come together and has moved the profession in a direction that I think is really fantastic. And you've obviously contributed to that alongside Allison as well, which is incredible. So thank you for that. Today we're going to talk about one of those big projects that you are, kind of, I wouldn't say you haven't wrapped it up. It's just sort of wrapped up in terms of the like mobilizing of the community piece. Let's debrief it. What has been the mobilization, the push with diagnostic imaging in BC for physiotherapy? I'm curious to actually learn a bit about like your experience for you, like, and how that went for you. Like, how did it feel to really like have such a positive movement within the community with that? Yeah, I'm curious.
Yeah, I mean, that's a few questions with that. I think first out, I'd be remiss not to actually give a shout out to the old PABC Scope of Practice Committee.
Mm,
They had been trying for years, if not a decade. So the way I put this to people is I think I'm the right person at the right place at the right time. So
mm,
these efforts have been made, but the two main things that have really changed to make this such a positive effort right now is you already mentioned it. There's a lot more research. So if we even go 10 years back, this was emerging. We know that physios have been able to order imaging since 2011 in Alberta, 1999 in New Zealand, and then
mm,
1972 in the US. But in the last like 5 years alone, a huge amount of research that's all positive. That's one. And then the other thing in terms of timing of why people are now listening is most people agree the healthcare system's not doing well. So those
Mm-hmm.
two things, more research and then the system not doing well, people are able to listen right now, if that makes sense.
Mm-hmm.
And then in terms of, I think, and then maybe just go back to your initial question. So that's like the
Yeah.
first thing that I want to say.
Yeah, well, and I'm curious like what your experience was like with it because I feel like you had such a positive response from the physio community. Like, did you connect with people that you wouldn't have necessarily expected to connect with otherwise? How did
Yep.
it feel to kind of just go through that experience?
Oh, yeah. I mean, I think I kind of, I think actually I got a feedback from Marie Westby after the panel forum, and she was like, "I could hear your enthusiasm in your voice, Jason." And I have to admit, this is a passion project. Like I've gone above and beyond just my like 2 days a week at PABC because I truly believe that our role as physios, like day to day when I'm in the practice, and I'm like, okay, you don't have a primary care provider. Okay, what do I do here? Okay, this is I've got a young woman and she's in her late 20s and it's a 2 year journey after her snowboarding injury, and it took her like a year to actually get like imaging and any sort of consultations, and it's she's in her 20s and it's like, okay, now like if this was a little bit more efficient, think of what our outcomes could have been. So I see this
Hmm.
day to day. The physio support didn't surprise me at all. Like we
Hmm.
know that physios want this, and it's like you're preaching to the converted. Where I was really impressed and what I loved the most about the consultation was it was across different
Hmm.
professions, and it
Hmm.
really was an example of bridging public and private physio. So
Hmm.
speaking to a bunch of physios in the private practice world, each and every health authority, I had contacts with all the senior health directors. We reached out to the BC Radiological Society, the BC doctors, a bunch of nurse practitioners. There's
Hmm.
explosive support from even, I think it's called the Rise Health Clinic in Vancouver. It's an MP-led clinic that they were
Hmm.
supportive. I spoke to representatives of the unions. One day when I was working out like mid-February, I was like, who else can I actually talk to? I thought, okay, how about local government? And then I was like, okay, how does that relate? So then I went online and I'm like, okay, what do actual local governments do? So then to put this in loose terms, is local government and municipalities do have a role in healthcare, which is a misconception. So federal government provides the funding, and then the provincial government makes the decisions how it's spent. But local government does have a role in preventive health, so i.e., run
Interesting.
a rec center. So they're trying to keep the citizens healthy. And then reactive health, so during the pandemic response. So the other part of this consultation that I loved was connecting with local government. I emailed every major municipality and city in the province, and the support that we got was overwhelming. So that I have an email directly from Mayor Sims of the city of Vancouver, Abbotsford. We have a ton of teeny tiny communities where it's really evident where physios can work to their full scope of practice, care would be
Hmm.
improved. So long story short, I think the physio world, it was great to connect with so many physios, but I think what was really unique was against all the professions, public, private, all of the layers of government as well. I think that was probably one of the most rewarding parts of the job.
Wow, that's really cool. Yeah, and I know I've kind of heard you talk about some of the stories of the specific people you connected with and the unique just kind of layout there. So yeah, that's awesome. And I think that also speaks to the support across the communities as well, which is really great. And I'm sure we'll break that down a little bit more here. I'm curious to really break this down. Why is this such an important ask? And like how can this truly help our medical system? Like what does the data show that the potential impact could be if this is a go?
So I think in large terms, so the diagnostic imaging, how we have phrased this is we know that when physios work to their full scope of practice, access improves, costs go down, and patient outcomes improve.
Love
So
it.
when we talk about full scope, there's kind of a laundry list. You know, some physios want it all and they want it all right now. But when you actually look at the research, number one for physios to work to full scope, to have that impact on the medical system to improve care, it's ordering diagnostic and imaging. That's what's
Mm,
most consistent in the research. So the a nice clear example is a really bad ankle sprain. Maybe it's from sports, you've fallen off a ladder, and it's like, okay, is this a grade 3 sprain or is it a fracture? If you or I can order that x-ray, we're going to be able to provide 100% of that care. You take
mhm,
the need, even if the client or patient has a primary care provider, they're no longer needed. So it's going to streamline care for a large proportion of clients. In the open engagement process, the Ministry of Health, there was a whole table and there was 10 professions whose scope was looking to be expanded. And their rationale for giving us the ability to order diagnostic imaging was 16% of all cases that present to an emergency department are musculoskeletal. So that's almost like a quarter that physios can have a real impact. And there's even research, I kind of grouped it just to be clear when we're talking about diagnostic imaging. Most of the research, I'd probably say about like 85, 90% has been on musculoskeletal science. In that grouping, though, is also trauma care. So there's some research that comes out of Australia that says, okay, these are physios that have more advanced skills. So yes, they could order diagnostic imaging, but then they're going to be able to actually, do other splinting and whatnot as well. So they could do trauma care or other wound care. And then rheumatology is also grouped in that. But just to be clear, it's mostly about streamlining musculoskeletal care. And as you know, we're experts with that. The other two pieces that were in the research of where we can help would be vestibular, so dizziness. So that could be appropriate in primary care or emergency departments. And then there's a few on pelvic health or women's health. Those were more in kind of tertiary clinics where physio was doing some triage. And then there was a couple articles about pediatrics or even openness of pediatricians to want to work with a pediatric physiotherapist.
Yeah, and it's interesting because lots of MSK, but you're right. Like we do see vestibular, we do see like concussions, and obviously imaging is a different ballgame there. But yeah, it's not just MSK that we're bound to. But you're right. Like there is so much MSK stuff coming even into my urgent care center that we're at the urgent care keeping out of emerge, but there's so much redundancy often when I see these folks come in. I'm referring them back to the NPs or the doctors for that imaging because, they've come in for that ankle sprain that, or may be a fracture, an avulsion fracture, something like that, and their Ottawa rules are positive. I'm sending them back over to an NP or a nurse practitioner, or sorry, GP or an NP to get that imaging, and it becomes redundant. So you're right, that care could be done, A to Z
Mhm.
with that ability to order that. So, I mean, I agree. Like I see that every day. Where can physio, so you mentioned it earlier, Alberta, where else in Canada can physios order imaging, and where else even in the world? Like where is most of this literature and research coming from?
So vast majority, so the early research is from the U.S. military. So that was out of necessity. So that was 1972. So there's some interesting research that comes out of the U.S. military. That's where it started. And then, as I had mentioned, New Zealand was 1999. And then after that, the bulk of the research has come from Australia and the UK. So that's a lot. And in the UK, physios can order imaging. They can order basic prescriptions. They could do injection-based therapies. So that's international. I don't have the exact stat, but the World Physio Association, which I think is rebranded, no, it is now called the World Physio Association. It was called something before, but when they actually looked at all the member nations, it was I think it was about 40% of member nations could order diagnostic imaging. So there's other countries like in Scandinavia, Norway. When we look at Canada, it's the Yukon, Alberta, Quebec, Nova Scotia, and PEI are currently a yes. Ontario, their open engagement consultation just ended in the fall. They've been trying a long time. We're trying to avoid their advocacy efforts. I mentioned at the forum, they started and got partial legislative amendment in 2009, and their open engagement process just ended in the fall, and then ours just started. So I think that's an example of we don't want to go down that route. It's overwhelmingly been positive. No decisions have been made, but that's kind of the jurisdictional scan. So I think the one thing I tell people is I love if this was actually an innovative idea. And wow, PABC's got this great idea. Why don't we just try this and do a pilot? No one's thought about this. It's the complete opposite. This is like, there's so much research. Like, I think even when I was slightly nervous, I was like, you told me, oh, we're going to delve into the research. I have read hundreds, if not thousands of articles. So I don't have the brain to be like, oh, Crowler et al. 1996. There is just so, like, it's a plethora of research. Even when I started this and I did my initial kind of like scan to be like, okay, what is known? I first connected with some experts. Like one of them is Jackie Whitaker. So she helped to start the program at the U of A. And literally that was the word she used was plethora. Like it's just like There's so much. Now, we didn't do a systematic review, it was a scoping review, but the evidence is there. And this is not a new brilliant idea. It's been done for such a long time that, yeah, we're just trying to like press play in a different province, essentially.
Yeah, and almost catch up
A
to
hundred
everywhere
percent.
else.
That was, it's interesting when you say catch up because on Friday I met with my MLA, Brennan Day.
Mm.
He is the critic of senior and rural health. So one of the things I'm learning is when you do lobby government, you have to lobby both sides.
Mm.
So we've already met with the Ministry of Health. There was that open engagement process, but on the same hand, we've reached out to the opposition government. And yeah, essentially, he asked me for a briefing note for today. He's actually addressing today the Ministry of Health and gets to ask 20 questions. And it's kind of interesting. I've had to do so much different crafting and so many emails of who the audience is. And so I don't know if I'm a geek. Literally on Sunday when you were in the board meeting and I was in the office, I was watching Question Period. And so, no joke, right?
I
Like you
love
think
it.
it's like super dry, but he asked me to frame the question differently. So it's like
Mm.
it has to be somewhat abrasive if you watch Question Period. It's like you get in front of the minister, you're like, the healthcare system is not doing well. Please, Minister Josie Osborne, tell us what are you doing to rein in costs, et cetera, et cetera. For example, where do you stand on increasing the scope of practice of physiotherapists to improve care? But it has to be framed as a larger question for accountability in a way to hold government accountable, if that makes sense. And in that briefing note, I was very clear. It's like, yeah, this is not innovative. We are behind,
Mm.
right? We are actually not leading this. I think as a profession, what I'm most proud of is we have been so collaborative in terms of our efforts. Like
Yeah.
I think this is not going to work unless this is a team effort across all of the professions. And I think that's one thing I've made clear. I was talking to the Saskatchewan Physio Association, and they're just getting started. And I remember they're like, oh, there was one member on the board that was like, no, the doctors are not supportive. We're not gonna bring them in this conversation. I was like, unequivocally, I disagree. Like this is a
Mm.
conversation. If we want team-based care, and that's what the research shows, is that when physios can work in team-based care as a partner across all of the different professions, that's when care is better. And I
Mm.
think the way I kind of explain it to my clients when I'm working is think of inpatient care. So if you've been unfortunate enough to actually be in a hospital with a major illness, or you've seen maybe you've had a kid that's been born in the hospital or an older adult, when you're in the hospital, you're going to see the physio, you're going to see the OT, you're going to see the dietitian, you're going to see the social worker, the physician, the healthcare assistants, all on one day.
Mhm.
So why is that not being done in outpatient care? Like that model's already been done and we know it works and it's collaborative. And I think of my old experience when I used to work at the Child Development Center. It was amazing. Like I shared an office not with physios. I shared an office with an RN and an occupational therapist. And I had the personal email of the orthopedic surgeon that every day was doing surgery on the kiddos on our caseload. And I loved it. And that's the model of care that we're trying to have. And the respect I know when I was on that team was huge. Like my experience working alongside nurses and OTs, I'm like I know like what we're able to do. I'm like, okay, slings and special equipment. Okay, you got to go talk to Julie, right? She's the OT. She knows her stuff.
Yeah.
Okay, wound care, Margaret, I need your help. Like, right? Dr. Weatherhead, okay, there's a complication. Like, what do I do here? So I think that's essentially we're trying to replicate that model of inpatient care in the outpatient
Mhm.
world. Um,
Yeah.
One thing I didn't get to talk about at the forum was the model that I think is going to be the future is, are you aware of the Gateway project at UBC?
No, tell me more.
So it hasn't opened yet. So it's going to be a teaching clinic. It's either 10 or 12 professions at UBC, exactly what I just spoke about. So that is you got 10 to 12 and I think the other thing maybe I didn't bring up as last piece is even when I was at Queen Alexandra, a real big piece of overall health is having a mental health professional on these
Oh yeah.
teams. So I know at the Comox First Nations, it's physicians, nurse practitioners, an occupational therapist, and our RCC. So I think that the Gateway project, if people are not aware of it, you go online and look. It's just about to open in the spring, but it looks absolutely fantastic. It's a teaching clinic, and all those professions are in the same place. So I think that's
That's
the future.
amazing.
And you and I had like a prelim conversation about your work, but it's like
Mhm.
you're doing your work and it's here. It's
Yeah.
like if you actually have more of that partnership with those other professions, the care and access is going to improve. Like it's unequivocal that it will improve.
Yeah, absolutely. And I fully agree with your point about mental health being a component of this. Like, we know these things go hand in hand, mental and physical health. So, yeah, I 100% agree. I'm going to look more into that. That sounds very like intriguing to me and up my alley for sure. I actually do want to talk a bit about what the literature is showing. What are some of the key points that we're seeing that are in such support of diagnostic imaging being something physios can order in BC?
So number one, and it's kind of related to barriers. So when we've had discussion with physicians, the number one concern of some physicians is that they think that the imaging requests are actually going to go up. So total volume, you let physios order imaging, there's going to be an increase of actual diagnostic imaging requests that are put in. We know that's not true. So we know what is true is that when physios order imaging, we are very conservative. So it's in the literature, we order imaging requests at the same rate, or in some cases, actually lower than other physicians. So when we order imaging, it's usually for a reason. I think just looking at one of the US studies, it was anywhere from 4 to 9% of cases they would order imaging. It was fairly small. But yeah, it's very clear that we do not order that many diagnostic imaging. So I think that's part of our knowledge mobilization is that was something to address both with the doctors at BC and with the radiologists as well. And the radiologists obviously had concerns that there's not enough radiologists. So if there's more physios ordering scans, it's going to be an issue. The other thing, and it's related still to that general theme that we don't order that much imaging or less, is the other thing that we've been really clear with the physicians is that not all physios are going to do this. So we could talk about it later, but this is a restricted activity if authorized or certified. We know in Alberta, I don't know raw numbers, but percentage, it's about 12% of physios in Alberta order imaging. Their threshold to order imaging is you need 5 years of clinical practice plus 2 U of A courses. It's about 30% of physios in Nova Scotia, and it's an easier model. So you just have to prove your knowledge base. I have a hard time saying it. It's called the attestation model. So there's not even one course that you have to take. That said, if you're in the Nova Scotia Health Authority, they have specific requirements and they say you have to take this specific course to do that. But long story short, not all physios are going to order this. We know that the actual imaging rates, that is an overall theme, we order at the same or at a lesser amount than physicians.
Wow, I believe it. Like if the default is not being able to order at all, I feel like, just from my perspective as a clinician, I would really only order it when I really want it because it's already been such a limiting thing. And I mean, maybe
Yeah,
that would change with the ability to actually do it, but that's kind of the way I would see it, is it's kind of this like
100.
extra luxury I have.
You know what, I think that could, well said, and I think it then loops to like another major theme. So I think what you just said is another theme is we call it treatment plan changes. So if you or I are going to order imaging, there's a reason. And I just had this discussion yesterday in the clinic. Someone and they had some hamstring tendinopathy. They were like, "I'm largely this is probably driven by your back, probably thinking like S1, S2. But if you went and got an MRI tomorrow, will it change your treatment? No,
Yeah.
you're not a surgical candidate. In this case, this gentleman, he was like 38. He was going to the World Masters for Ultimate. And I'm like, it won't change
Yeah.
what needs to be done. So a good real analogy to use for the treatment plan changes, a lot of people don't know this. It's called surgical conversion rates. So if
Yeah.
you or I were to refer to surgery, people are most likely going to actually get the surgery. So we're not going to
Right.
refer on to orthopedic surgery until we've exhausted the rehab and more conservative care. But we know when compared to even other physician specialists that we have a higher surgical conversion rate. So two of our main interest holders in the position statement were the BC Children's Orthopedic Clinic and then the Brenda and David McLean Integrated Spine Clinic. And those are both prime examples of that is you have a physio that is doing the triaging. And so someone would come in, it's like, okay, not time for surgery, come back and, follow up in 6 months time, and then wait. As soon as the physio like presses play and be like, I think you need to get surgery, they actually go on to get surgery. Whereas if another practitioner and we know that we order that surgical conversion rate is very high with physios. It may be a nurse practitioner or a family physician, their surgical conversion rates are lower. So they haven't exhausted those other means to avoid surgery. So physio-led triaging, you're only going to see that orthopedic surgeon if you need it. And so it's high. So that's a really key metric. That's an efficient pathway of care. You're not going to waste the surgeon's time. What are surgeons supposed to be doing?
Surgery.
Surgery, right? So even in terms of that model of care, if we're even more forward thinking, we think the physios could do the triage and decide if surgery is even needed. And then after that, there's been some cases even in our province where some of the physios were even providing complex post-op care after total hips and total knees. And this was a while ago. Again, nothing new. I remember being a student. I think it was we determined I connected with an old Dave Troughton and with Island Health, and it's like 2007. And I remember going and like observing him in the clinic, and he was taking out staples like after a total knee in 2007, right? So like he was the one doing all that care. So essentially, in that model in Island Health, it was like, yeah, the surgeon's the one doing the surgery. So the physio is doing the pre and all the post-op care. And then again, if we could order diagnostic imaging, then you could rule out things like a DVT or any complications like that. We have a voucher program at our clinic where Island Health does not have enough outpatient physio. So they come to private practice and they get 10 visits for a total knee. They get 4 for a total hip. And with that, there's been a couple times where since about October, maybe about a half a dozen times, I've thought someone's had a DVT. What's the only option? Okay, you got to go to the ER.
Yeah.
Like no joke. That's another prime example of sending people to the emerge, and it just stymies up the emergency department. If you or I could have ordered that ultrasound, 100% comprehensive total joint arthroplasty rehab pre and post.
Yeah. Exactly. I mean, it makes perfect sense to me. Funny you say it. I actually remember I took staples out back in like 2013, 2014 in the 100 Mile Hospital post-surgically on placement. It's my hometown. I'm not sure if it
Yes.
was just because it was a rural community and all the surgeries
Yeah.
were happening in Kamloops, but I definitely remember doing that. And now I occasionally go and cover at the 100 Mile Hospital, and we can't do that anymore. And I
And
was like, what?
what it makes, it's interesting you talk about 100 Mile House. They were one of the municipalities that explicitly gave us a letter of support. The great thing about the local government is we've got like big cities like Vancouver and Abbotsford saying this is a great idea. And then we've got these, Williams Lake, 100 Mile House, like Enderby's, teeny Ladysmith, like on the island. They're like, yeah, this is kind of like a no-brainer. Anytime I have this conversation with any client, they're like, yeah, makes sense.
Right?
So
Well,
yeah,
100 Miles, one of those emergency departments that is closed on average, like, multiple times a month. They're
yeah,
struggling. Like, it makes perfect sense to me. But I mean, I think we both agree on that point.
yeah.
What has, if any, been the pushback? I mean, we talked a little bit about the fear of just ordering more imaging in general, which we've covered well. But has there been any other pushback, and like who is maybe providing that pushback against this?
So the only pushback I have to rephrase. I wouldn't say pushback. I would say it's a reservation. Would
Mhm.
be from the doctors at BC. So we had a positive meeting with them, and they appreciated the collaboration that we had with them. They were clear that they had about 500, more than 500 of their members provide feedback. So there's actually a summary statement of like all the 10 professions in terms of the scope advancement. Long story short, they came out and made an official statement, and it's forward facing that they did not approve it for
Mhm.
the concern of the increased imaging rates. And if we were more specific on what the actual rollout would look like, they would maybe be supportive. So I think I think from the actual leadership team in the meeting, they were open and they liked the collaboration. But as a whole, they had 500 plus physicians say we have concerns, and the two main concerns were increased imaging, like as a total volume. That
Mhm.
was always easy. I've just basically pointed to the research.
Yeah.
The second one, to specifically answer your question, that was brought up as a concern, is what do we do with incidental findings?
Mhm.
So I think in the position statement, there's an example. Okay, maybe it's frozen shoulder, but then it's like, oh, then you order the imaging and it's actually an osteosarcoma, and that person doesn't have a primary care provider. What do you do? To answer that question, I usually defer to the Nova Scotia model. It's forward facing what they do. Long story short, if someone does have a primary care provider, the primary care provider is CC'd to the diagnostic and imaging request. So then if there is a red flag, their physician or nurse practitioner knows. The second thing, because the next question is what happens if someone doesn't have a primary care provider, is they have a 24-hour hotline. So if you want to
Wow.
be able to order imaging, it is very clear, even in our discussion with the Ministry of Health, to do a restrictive activity requires more responsibility. So in terms of the responsibility, there has to be someone that is available to answer that 24-hour call. So if it goes back and it looks like it's a red flag that needs immediate follow-up, you have to be able to answer it. So we haven't talked about the specifics, but if that model is replicated in BC, I would imagine it'd be like a clinic. And it'd be like, okay, you can't have maybe one physio on 24 hours, but okay, our clinic needs to make sure someone's in charge of this phone line 24 hours a day in case there is something. And when we've brought that up, even some of like the physicians are like, oh, like really, there's very rarely anything that has to be dealt with in a 24-hour period. It's like you could deal with it on a Monday. But I think in the end, that's playing it safe. So to address that and some of the why it may be slow to phase out is there has to be that pathway to deal with those incidental findings. I think in the position statement, it was I think even to bucket this out, there's the real red flag issues that have to be dealt with, and then there's like incidental findings that don't need any follow up. But like at MRI imaging, there was like one study where like in a quarter of requests there was incidental findings, like in 25% of the time. So you got something else that you were not expecting. So the example that Dr. Adam Thompson gave when I was talking to him, when we talked to the doctors at BC, is like, oh, that's what happens if you just have some like a little bit of calcification, so a vascular issue. It's non-emergent. What do you do? And then I was like, well, that's non-emergent, but then that's a refer back to the primary care provider. And that was maybe their third concern is does this then increase the load of work for the primary care provider? So there has to be this back and forth to be like, okay, I as a physio ordered the x-ray for like a knee issue, right? But now it showed up something vascular. But maybe his point was the primary care provider already knew about the vascular issues. Like for the last 10 years, it's been a non-issue. It's well managed, but it's just one more other piece of paperwork where it's like, okay, well, it's a non-issue. It created more work. So I think the other thing of, although it's been overwhelmingly positive, it's going to take time to deal with that. And so the incidental findings is, I think the two pushbacks to really summarize it is the volume of scans, and the volumes of scans we know will actually not go up. The incidental findings is actually not a barrier. It's just something that we have to look at the logistics of actually doing that. And then it hasn't been brought up explicitly, but with the Ministry of Health, a big kind of barrier to implementation is going to be medical records. I mean, I used the example when I was at Forum. I'm like, at our clinic, the only way that I can request imaging is we send a fax to like a physician's office. When I was doing this position statement and I was going online to try to find the primary care provider clinics and these, and NP clinics, almost none of them have even email addresses that are forward facing. So it is like to do this properly, there's gonna have to, I know even on a federal level, they're looking at electric medical records. Like it's a barrier to good medical care. So that's gonna have to be in place before any imaging is ordered.
Yeah, and that makes sense. I mean, and I think that's a barrier across the industry. That's not exclusive to physio, really. And like in the private system, everyone uses Jane. It's got plenty of capabilities. But yeah, there definitely seems like there's going to have to be some kind of just like clunky administrative logistics that need to be figured out within this. So, I mean, that makes a good opportunity to talk about what this actually might look like as it rolls out. And I'm sure everyone's asking you, "Well, how long is this going to take? What's the timeline on it? How many times have you answered that question?" But yeah, like what is sort of the timeline looking like, and what will it actually look like if/when it does go into place?
So I can only answer some of those questions. I don't have the crystal ball. I think we've been successful. The just to be Our advocacy campaign basically ended with the open engagement. It wasn't just by coincidence. So it's been on the radar, as I said, with this like for the past 10 years. It all started last January. Andrea wrote a letter to the Ministry of Health. And then when we met with the Ministry of Health, they were clear that they started working on this March of last year.
Mm.
And so we kind of knew this was like well on their radar. So that's why last May, Andrea tasked me with like, okay, put together a task force, let's get going. So it was on the radar. All of that said, because of this open engagement process, there's going to have to be an answer. So if you ask me this question just because we did like general lobbying, it would be much wider. But we would think that there would be some sort of like decision made in the next couple months to be like yay or nay.
Mm.
So a yes or a no. So that would probably be coming out in the next bit. What it actually looks like after that, this is where even with our own diagnostic and imaging task force, people want things to happen quite quickly. Yep. So it's not gonna happen super quick. There's a lot of things that have to happen. And I think what I even just do, and I'll reiterate it now, is PABC in simple terms, we advocate. So that's our job as a nonprofit association. We do the advocacy work.
Yes.
What does UBC do? In simple terms, they educate.
Educate. Yes.
What does the college do? They regulate.
Mm-hmm.
All three of those systems have to come together, and I can say up to this point we have. And I highlighted in the forum, all of those parties were at the Ministry of Health meeting, all for one reason, all supportive. But what it actually looks like, we're not, as PABC, we have the recommendations in the position statement of what it should look like. So we're suggesting a 2-year evaluation plan. We're suggesting that it should be a restricted activity if authorized. So to be clear, this is going to require probably more advanced clinical practice and imaging. The research is very clear on that. But PABC is not making the decision of what the regulation looks like. We've made the recommendations. The college is going to have to decide upon that. Mm-hmm. And then I bring up UBC as another reason because there's also discussions in terms of what is going to be the pre-approved education. So already the University of Alberta coursework, that's been one. Those interest holders, when I talked about this, the two BC Children's in the spine clinic, some of those physios already have their imaging education taken from the U of A. So that's most likely going to be a pre-approved pathway. But then there's also the discussion about UBC actually coming up with their own educational pathway. So we don't know exactly what it's going to look like. We do know there's going to have to be some evaluation. And I do think I want to get the messaging out there that to deal with a little bit of, and again, I don't want to use the word pushback. I think there's concern, right, from some of our partners, mainly the physicians, that it's okay, is this going to increase the burden on the medical system? Is it going to be good quality care? To do that, it's been very clear in all of our discussions that like the BC Children's and spine teams, those are no-brainers.
Yeah.
For physios in those practice settings.
Yeah.
Why is that? They work side by side with their orthopedic surgeons, two of which came to the Ministry of Health meeting and were pushing for our profession. So they have physicians on site. They are both using the same electric medical records. They have imaging on site.
Yeah.
They have all of the protocols, policies, procedures already done. So the other thing of what it looks like, most likely in the conversations with the physicians and with some other senior health leaders, is it's going to probably be a phased rollout. So essentially, if the Ministry of Health comes back saying like 3 to 6 months, like, yep, great idea, it's probably going to start for those physios and our colleagues in those settings because it can happen almost immediately. There's very little logistics that have to be changed, and then it would roll out to the community. The other option, and so some physios, especially in private practice, are just like, no, it has to all happen like right now. If that's the case, there's going to be significant delay. So when you're asking about like timeline, if we want to wait for all physios to do this, myself included, when I work in an isolated private practice, it could be years. And I go back to the Ontario example, like 2009 to 2026, and our open engagement processes just happen within months of each other. We don't want to go that route. In Nova Scotia, the phased-in approach is how it happened. So physios in the health authority were able to order first, and then it was the private physios thereafter. So we don't have a crystal ball, but those are kind of like the buckets of the main things that have to happen. So we assume that it's probably going to be a couple months for a decision. And then the only caveat is that phased rollout. The other questions, because I do get specific emails some people are really wanting this to happen. So they're like, what coursework do I take? And I'm like, just wait.
Yeah,
Like
just
it's
hang
too
tight.
soon. And we don't even know. I mean, one of our recommendations in the report is, and one of the questions is, if you're a physio from the UK or from Alberta and you've already done the coursework, will that count? We don't know. That's going to be the college decision. That is our
Mm.
recommendation, that they should be considering the University of Alberta course, maybe a new UBC one, and then to have credentialing if you are a physio from another jurisdiction that's already been doing this.
Mm. What does advanced practice entail? Like, what do these courses teach? Like, what's the material that's within them? Is it like clinical or is it more like logistical? Like, what does that look like?
You know what? I can't answer that question. I was actually offer. I have not had the time. The other big one that's approved for Nova Scotia and Ontario and possibly Ontario is key clinical skills. So
Mm.
I haven't actually logged into the coursework. I've
Mm.
personally not done it. So I'd have to defer to someone like Maria or Stacy at BC Children's who already has taken it. I'm assuming it's like I mean, it's all the, I don't know if it's so much like the logistics, but I think it's like the appropriateness of when are you ordering imaging, right? What's more of a serious scan? So yeah, I can't give you a solid answer on that. But the one that's overwhelmingly accepted is the U of A course. And
Mm.
then out east, it's key clinical skills is another big one as well.
Yeah, yeah. Okay, cool. Yeah, I mean, I'm genuinely very interested in doing some learning as well, but I will hang tight until the time is
Just,
appropriate
just,
for that.
just wait. And I think that's I'll be one of the first to sign up for it, but I'm waiting to make sure that I'm only doing one that's going to be approved by the college. And I think if people are listening to this, I'm be like very clear, like just wait.
Yeah, just hang tight on that.
Yeah.
So obviously the open engagement period ended on March 31st, like you said, but is there a way that people in the community, patients, physios, other healthcare practitioners can continue to support the cause? Or, what does that look like right now in the community?
Yeah, I think it's a good question. I mean, you already said it. The open engagement process has ended. So that was on March 31st. So I wouldn't like push or urge people to do more, but if they are super passionate, this is, so at the beginning when it was released in December, we were asking people to write to their MLAs. And then it was like, we were a little bit shocked. All of a sudden it was like, oh, open engagement process. Oh, you now need to email professional regulations. So to answer your question, if someone in the community is passionate, I'd probably follow up with your MLA. And it's kind of like the squeaky wheel. Like people know. Like when I met with Brennan Day, he was aware of this, right? I emailed Anna Kinsey's office as well. She's the critic of all of health as well. So I think probably the MLA is the biggest access point. And in terms of even myself, I have personal conversations, but if you're looking for small talk in the clinic, patient partners. So I think, it just getting that word out to be like, yeah, yeah, it's a no-brainer. We need to do this. If you're supportive, you could write your MLA. But just to be clear, that the hard push has been ended. They're going to make a decision already based on the information that they have. And the only other thing I could say is we did make an explicit decision. Part of our advocacy campaign at the beginning, like we had a whole like kind of system was all dialed down as we were going to reach out to media. Our diagnostic imaging task force decided not to because as a whole, it's been so collaborative and positive. And I said it's in terms of even concerns from the physicians, it's not like there's not a barrier. There's like an open conversation to be like, have you thought about this? And have you thought about this? And so that's why even like the BC radiologists were very clear. They're like, okay, well, can we actually collaborate with UBC because we want to know what that content is. So when you ask the question is what content is being delivered, in the new UBC one, it may be a bit more dialed down, and the UBC and the BC radiologists want to be part of creating that educational pathway, which I think is huge, right? That collaboration and developing a pathway like this, I think that's how, as like all of the health professions, we need to start to move forward.
Exactly. And if the education is collaborative, then that's just going to facilitate the actual work being collaborative in the environment that it rolls out into. That's amazing. I like this is all just so exciting and inspiring and I like I'm so excited. Is there anything I've missed or like any other points that you want to get across or any other questions that you think I should have asked you about this?
I mean, I think the only other one, just in terms of like, as physios put like the physio hat on, is the other like major theme in the research was just when we do order imaging, like we really do it thoughtfully.
Mm.
And there's research in terms of interprofessional concordance with orthopedic surgeons. So if we go back to musculoskeletal healthcare and you look at gold standard, usually the orthopedic surgeons would be considered the gold standard. And physios are shown to have strong interprofessional concordance with orthopedic surgeons for two different kind of themes. One is that when we decide to order imaging, it matches that of what an orthopedic surgeon is. So it's like, okay, here's this case. With the orthopedic surgeon order imaging, yes or no? With the physio, yes or no? We agree. And that concordance is actually better than some other physician specialties and nurses. So just the decision to order imaging matches that closely to an orthopedic surgeon. Not 100%. I mean, I could pull it up, but I think it's like 70, like in the 80s. It's high. And then the second one of the interprofessional concordance is then when we order imaging, it often matches our working diagnosis, which is huge. So same thing. It's like, okay, I think it's a labral tear. Well, guess what? It's a lot of the time, and that matches that of the surgeon. So I think that's very huge in terms of musculoskeletal science, just how good at that we do. And I think to highlight that when I talk to some patients, people don't know this, but like at UBC, the main two professions that go in the cadaver labs are physicians and physios.
Exactly.
Right. And
That's
people don't know that. But I think we've covered like all the major themes, but I think that's a really strong one that we match our concordance with orthopedic surgeons is pretty huge.
wow. I mean, that just speaks to the quality of training that, physios are receiving in
Yes.
Canada and beyond.
Yeah.
I think that's incredible.
I
And
think, yeah, I think of it when you just, sorry to interrupt there, we're very clear with even our messaging, what you just said, is that the practice of what we do as physios is we are not asking to expand our scope of practice. We are asking to work to our full scope. So when you do look at that training and being in the cadaver lab and looking at what we're already trained to do, this is already within what our skill set is. So it is really trying to have like to realize what physios can already do.
yeah, yeah, exactly. It's the catch up.
Yes.
It's the catch up. Jason, this has been so incredible. I mean, I'm learning so much from all of this still too. It's amazing. What are some of your next projects with PABC, and do you have any call outs for the community right now?
Yeah, great question. So we chose diagnostic imaging as the key enabler to have physios work to their full scope. So that was number one. And then sequentially, the next two big ones. The next one, we have a call out for a primary care task force. And thank you for signing up. I think you're going to be a huge resource in the work that you're doing in the interior. And we're going to look at it's going to basically, first off, is doing a position statement on integrating physios into primary care networks. The advocacy, we don't have some of the answers where our advocacy efforts will go. For the diagnostic imaging, it was very clear. Do the position statement, lobby the government. For the primary care one, everyone is generally in support that team-based care does work. So I think after the position statement, our task force is going to have to deal with some issues like workforce planning. So using the example of yourself, I know that there was like 8 FTE positions for physios in the interior, just in Thompson, Okanagan, to work in these primary care networks, and only one applicant. So we're gonna have to address some of that. And then the next one after that, we know in terms of working to full scope is going to be integrating physios into emergency departments. That will be then the one after primary care. So if you're at all interested, the call it is still open. We're probably going to get the team together in the next week or two and then go from there.
Awesome. Jason, thank you so much. I so appreciate your knowledge, insight, and time on all of this today. I'm really excited to get this out to the community. So thank you again. How can people connect with you, like if they want to join any of these task force? What's the best way to get a hold of you?
Yeah, it's a good question. So just to be clear, the task force are open to PABC members and non-PABC members. So we're trying to bridge public-private. So anyone is welcome in the physio world. You can email me at jcraig@bcphysio.org, or I'm on LinkedIn if you're interested, or if any of you just want to learn more about what we're doing.
Awesome. I will make sure all those links are in the show notes as well. And again, thank you so much for your time today, Jason.
No, yeah, thank you for helping with mobilizing all this information. I really appreciate it.
Thanks.